Having completed the stress testing aspect of the examination of the craniovertebral joints, we can now look at mobility testing of these segments. And the first joint we'll look at will be the atlanto-occipital joint. The occipital condyles for this joint are convex, while the facets on the atlas are concave. Consequently, we will see that during flexion, the occipital condyles will glide posteriorly, while during extension, they will glide anteriorly. The test will be done in sitting if we are looking for a symmetrical dysfunction of flexion or extension. Now, with a symmetrical dysfunction, we are looking at the whole segment being unable to flex or extend, whereas with the asymmetrical dysfunctions, only half of the segment is unable to flex and extend. And we can test them both differently. So for a lack of flexion, we will be flexing the occiput and gliding it posteriorly on the atlas, which will be stabilized, and for extension, we will be extending it and gliding it anteriorly. It is also necessary to test side flexion, and we will side bend to the left and glide to the right, and side bend to the right and glide to the left. So, we need a wide, comfortable stabilization around C1. So we'll have a wide pinch grip around C1, like so. And this hand will come underneath the occiput and cradle the head against the chest. And the therapist needs to use their body as much for this as anything else. So stabilize in C1 so it doesn't come back as I do flexion. I shall flex the occiput and glide it posteriorly. And if I exaggerate the movement, it's a side bending movement of my body. So I'm testing both the physiological passive movement and the arthrokinematic simultaneously. For extension, I shall same stabilization, but this time I'll be trying to hold back C1 as I extend and glide forwards, like so. And for side bending, I shall maintain the same stabilization on C1 and side bend to the left and glide to the right. Now it's important that as you do this, you allow the contralateral conjunct rotation to occur, or there will be no movement available to you. This joint also needs to be tested for asymmetrical restrictions when there is a lesion on one facet rather than on both facets. And the test we can do for this is actually a little more sensitive than these in sitting. And we can take the joint to its extreme barrier. If you look at the bones here, I'll show you how this works. Remembering that the occipital condyles are convex, so that when I flex the joint, both condyles will slide posteriorly. If I then side flex to the right, like so in flexion, it results in a contralateral left rotation. This causes the left occipital facet to glide further posteriorly and stresses the articular capsule. If the articular capsule cannot be stretched by this maneuver, then right side bending will be restricted. So right side flexion in extension, in flexion rather, will test the contralateral facet, that is the left facet joint. With extension, they will glide anteriorly, and when I right side bend, this will bring the right facet further forward as we have left rotation occurring. So any restriction of right side bending will be from the right joint in extension. So we will do these tests in line, and these tests will not rely on direct stabilization of C1. Rather, the movements will be occurring around the axis of rotation for the atlanto-occipital joints, and it's essential that these axes are maintained. We will hold the occiput. There is no need to palpate C1. We will hold the occiput, and for extension, we will extend the occiput around the axis through the ears. And then we will side bend the head around the axis through the nose. And as we side bend, when we come to the end of the side flexion movement, we will then translate to the left to test the arthrokinematic and the full end fill. And to the right, we will be doing the same. So to the left. And as I side bend to the left, in extension, I'll be testing extension at the left facet joint. In flexion, we will flex the craniovertebral joints around the ear again, and we will side bend around the nose. The axes remain the same. And as I side bend to the right, I am flexing the left AO joint. If this movement is restricted, the right side bending movement is restricted, it's because there is a loss of flexion at this joint. I will side bend to the left to repeat the test here. And as with all mobility tests, I am looking for range of movement and end fill. It is not simply hypomobility, of course, that I'm interested in, but also hypermobility. Having tested the AO joint, we can now move into testing the atlantoaxial joint. And there are two ways that we can test rotation at this joint. We can induce the movement of rotation directly by rotating it in the direction that we're interested in. However, we do have a problem. The alar ligament on the left side will restrict the amount of right rotation that's available to me. So unless I do something to slacken that ligament off as I carry out the test, then right rotation will be restricted to only 5 or 10 degrees. So prior to doing the test, what I shall do is side bend the atlanto-occipital joint to slacken off the left ligament, and then I can produce the rotation. And it's only once that ligament is slackened off that I can effectively assess the mobility at the atlantoaxial joint. So we'll move back to Beverly, and I will stabilize C2. A wide pinch grip around C2, and this grip now will come around so that my little finger is over the neural arch of C1 and the rest of the fingers are over the occiput. And there is the grip on C2. Now, in order to right rotate, I will side bend the atlanto-occipital joint to slacken off the left ligament, and then I can test the rotation. Like so. If this ligament isn't slackened off, just to show you the difference, then that's all the rotation that is actually available. So it's important that this side bending is carried out prior to rotation mobility testing. And we're looking for the amount of rotation that occurs again and the end fill. An alternative method of testing rotation is to induce the rotation at the atlantoaxial joint by initiating it with side bending. And this test is done in lying, and we will have the patient supine, and this time we will side bend the occiput so that the movement initiates ipsilateral rotation of the axis. So if we're doing right side flexion, the axis will tend to move to the right, rotate to the right, which of course is contralateral rotation at the atlantoaxial joint. So right side flexion will test left atlantoaxial rotation. I will position my fingers in such a way as to facilitate this movement. The finger will come around the neural arch of the C2 so that I can grip the spinous process. I will then side bend the occiput, and I will pull the C2 spinous process in the opposite direction to the way I'm side flexing, thereby inducing right rotation if I'm doing right side bending. And from here I can gauge the amount of movement by the degree of displacement of the spinous process, but probably more importantly the end fill. Is it normal capsular, is it hard capsular, or is it excessively soft capsular? This test is actually a good deal more comfortable for both the patient and the therapist, and tends to be a little more sensitive than the test done in sitting. So if I test right rotation, I will do it by left side flexion of the occiput. So I will wrap my finger around C2 to grasp the C2 spinous process and neural arch. So that when I pull this way, I will tend to left rotate the axis. I will side bend the head in neutral flexion and extension
around the axis through the nose again, like so. And as I do so, I can feel the spinous process moving to the right. I will simply pull with it to gain that end fill. And I will show you the opposite test so that you can see the hand and finger position from this side. So again, just reaching around the spinous process of C2, take the occiput, side bend around the axis of the nose and test the range of movement and the end fill. Having completed this examination, it should be possible for you to make some sort of statement concerning the movement dysfunction that you'll find at the atlanto-occipital and the atlanto-axial joints. Is there a hypomobility present? If so, is it a symmetrical hypomobility where both joints are affected, or is it an asymmetrical one where only one joint is affected? And similarly with hypermobility. You should also be able to determine whether or not the segments are ligamentously stable.